Okay, so in the first video we talked about sort of the bones of the skull and the face, and now we're going to talk about some of the miscellaneous structures. We're going to start with the nerves, and we're going to start with the cranial nerves. Now there's 12 cranial nerves, and they're called cranial nerves because they actually originate right off the brain itself. And here are your first six, so cranial nerve 1, and each one has a unique function, either with a sensory function or a motor or a muscular type function. So if you look at CN1, cranial nerve 1, it's olfactory. So this is the nerve in charge of smell. Cranial nerve 2 is optic, which is the ability to see. Oculomotor, which is your pupillary reaction, be able to constrict and dilate. Trochlear is just general eye movement. Trigeminal would be facial sensation and then being able to open your mouth. So if you look at trigeminal, it has not only a sensory component and sensation of the face, but also a motor component, being able to actually open your mouth. Abducens is lateral eye motion. So these are your first six. You look at cranial nerve 7, that's facial expression, that's the ability to smile, frown, that type of stuff. And taste, which is both a sensation and a motor function. Cranial nerve 8 is acoustic or vestibulocochlear, depending on which textbook you're reading, and this is hearing and balance. Glossopharyngeal is cranial nerve 9, which is for swallowing and be able to speak. Cranial nerve 10 is vagus, which is your gag reflex. Cranial nerve 11 is actually very unique because it's called the spinal accessory, and it actually goes to trapezius muscle, and it allows you to do a shoulder shrug. It's really the only nerve that really innervates extrinsic musculature. And the number 12 is hypoglossal, which is to be able to move your tongue and the strength of your tongue. So when you look at these 12 cranial nerves, they can be assessed in a clinical setting. When you see people getting any sort of head or neck injury, they will run through a cranial nerve assessment. If someone's having problems with any of these types of functions, you might think it's a cranial nerve. And there are a variety of different ways to learn these. And the next slide are going to be two mnemonics. And keep in mind that these are mnemonic devices that I did not come up with. These are taught in med school and PT schools across the world. So if you don't get mad at me, don't get offended. We found that if you put a little bit of crudeness into something, people tend to remember it. So if you look at the mnemonic device, to touch and feel a genuine virgin at home is the mnemonic for the 12 nerves. So olfactory, oculomotor, optic, etc. So each letter represents the 12 nerves in order. If you come up with a better mnemonic or a different mnemonic, please feel free to use it. You don't have to memorize this. I will not test you on that mnemonic device. The second mnemonic device, some say Marilyn Monroe, but my brother says Betty Boop, has to do with if the nerve is a sensory or a motor nerve or both. So if you look at olfactory, olfactory is sensory. It just deals with smell, and you can see how they line up. Olfactory, sensory. If it says M, that's a motor. So oculomotor is pupil reaction. It's just doing motor. B is both, meaning it does both sensory and motor. So you look at trigeminal, it not only does facial sensation, but also does eye movement. And this is important to realize in a clinical setting because you might have some nerves, if they lose their sensation, you know that they might have a cranial nerve deficit or they might have a motor deficit, etc. So just understanding that some nerves are sensory, some are motor, and then some actually have both those type of functions. So that's a brief overview of the nerves of the brain and the cranial cavity. We're not going to go into a whole bunch of depth. We could spend a whole course just going over cranial nerves. Just want to sort of give you a brief overview of it. Mentioned it earlier, but the orbit of the eye has four walls. The frontal bone is the roof or the superior orbit. The ethmoid bone is actually the medial. You'll actually see a little bit of the maxilla also, but the ethmoid bone, which is really tough to palpate, is actually the medial wall of the orbit. The maxilla and the zygomatic bones make up the floor or the infraorbit. And then the frontal process of the zygomatic and the greater wing sphenoid is the lateral. And if you actually look at the skull, the apex is sort of the eye canal actually tapers to a cone, and the apex is the most distal aspect of it, or the tapered aspect of the orbit. Another thing you want to look at are the sinuses. You have three main sinuses, and you can see anatomists are lazy, so they simply name the sinuses for where they are in the bone. So your frontal sinus sits right here with the frontal bone, your ethmoidal sinus right here with the ethmoid bone. You can see that medial border of the orbit. And then your maxillary sinus right down here in the maxillary bone. And anyone who's ever had a head cold or something like that knows that your frontal sinus will fill up, your maxillary sinus will fill up, etc. So again, these are just sort of different miscellaneous structures that we're talking about. Now, the temporal mandibular joint we mentioned earlier in the first video, and this is important. It is a synovial joint, and you guys remember the properties of a synovial joint: has a capsule, has cartilage, has synovial fluid, etc. And what it is, it's the condyle of the mandible, which is right here, and it articulates at the temporal bone. So this is the external acoustical meatus right here. There's your mastoid bone, so we can orient ourselves. So if you use the ear canal as sort of your major landmark, just anterior to it is the temporal mandibular joint, just posterior is the mastoid. And you can actually palpate this quite easily. If you actually kind of put your finger in your ear and chew, you actually can feel the condyle kind of moving and grinding inside this joint. There's actually a disc that sits right here that sort of helps to cushion where the condyle is. And you have a lot of motions here at the jaw. Depression, which is dropping your jaw, elevation, closing your jaw, protrusion, which is sticking your jaw, your bottom jaw out front, retrusion is bringing it back, and then going side to side lateral motion. And these can dislocate, they can sublux, they can click, they can pop, they can do a whole bunch of different dysfunctions. But the temporal mandibular joint is a pretty important joint here. So if you want to look at it again, we sort of switch it around. Here's the zygomatic arch to orient yourself. There's the acoustical meatus, so always use this as your landmark. Going just posterior to it, there's the mastoid. And right here is what they call the mandibular fossa, because that's where the condyle, the mandible, should be sitting in, okay? So there's the temporal bone, etc. So just kind of reorient yourself to that. Going into our sort of our final bit of sort of miscellaneous structures is the anterior aspect of the neck, which some people get a little bit freaked out about. But the hyoid bone, which sits right here, is actually just distal. You can't see it, but your mandible would actually be sitting right here. So the hyoid bone is just distal to it and back. So if you start on your hyoid and drop down and kind of push in a little bit, you can actually feel this hyoid bone right here. You have your thyroid cartilage, which is the Adam's apple. And when I say opposite C4, that means cervical vertebrae 4, it's at the same level with it. And then your cricoid cartilage, which is a very dense, thick piece of cartilage just distal to the thyroid cartilage. So when you actually palpate the trachea, it actually will feel sort of like the ribs of a vacuum cleaner tube. And we'll palpate those in class. But these are very delicate palpations, and they're very close to each other, so you need a very, very fine touch to be able to orient yourself to the differences. The triangles of the neck, you have an anterior and a posterior triangle, and we're going to talk about sort of the major landmark, which is the sternocleidomastoid muscle. But you have this anterior triangle, which contains your carotid arteries, and then posterior triangle. So when you look at it, you can see the sternocleidomastoid sits right here, major muscle. It goes to your mastoid process. So again, external acoustical meatus, go just posteriorly. There's the mastoid, sternocleidomastoid muscle. So this would be your anterior triangle. Back here would be your posterior triangle. And the reason we care about the triangles is because what sits in them, and that's your blood supply. And you actually have a ton of arteries that sit and supply the brain and the skull and a variety of muscles here. For our purposes, we really care about the temporal artery, which sits right here, right by the temporal bone. Again, anatomists are lazy, so they're going to name the artery by the bone that it goes near. And then the common carotid artery, which is number 1 right here. And this is the one that you kind of take your pulse with. Whenever you take your pulse in your neck, you're looking for common carotid, excuse me, but you can see it has a lot of different branches which go and service the majority of the skull. So if you want a more 3D look of it, this is how it looks like. So you can see coming up through the chest cavity, your common carotid splits into a right and a left. It comes in here through the temporal common artery, and then it goes and supplies all your face, etc. So with this blood supply, you can see why when you cut yourself, it doesn't need to be a big cut, you will bleed quite substantially because it is a highly vascularized area. So those are sort of the miscellaneous structures of the skull and face. Some of these we can palpate easily, some of them we can't. We're going to try our best. The last video we're going to go over are just the muscles.